we have got one of the maximum number of deaths that comes from poison. Abroad, it's very different from India. So we are also going towards abroad now. Abroad, usually the poisoning is because of increased use of recreational drugs. Okay, like cocaine, like LSD, and things like that. We are also going towards that, but in India, majority of the poisoning is because of deliberate self-harm. DSH is called. It's because of deliberate self-harm. Okay, because of the amount of poverty that we have in the country. We are in the city, so we don't really recognize the amount of poverty that happens in the villages and rural area. But we've got maximum amount of deliberate self-harm that occurs, and that's why the rules of pesticides in our country is very strong. The rules of pesticides in our country is very, very strong. I mean, we have clear registered pesticides that are there in our country. You can't make anything that you want. In fact, Kerala once had even banned a few pesticides. There are many pesticides that are banned, okay, in the country, many, okay, and Kerala has always been the leader in banning those pesticides, and then the country takes it over. 2007 they banned a number of pesticides. In 2011 the country took it over. So like that, many pesticides are banned, many pesticides are regulated. Okay, we are an agricultural country, and that is the reason that we have so many pesticides. Okay, we are an agricultural country. That's why we have so many pesticides. We have so many of these herbicides. Okay, we have so many of these things that prevent crops from getting spoiled, and that is unfortunately used for deliberate self-harm. Okay, so in the city per se, you might not see any of these big poisons coming. If you go to the villages, you will probably get many of these herbicides. You know, the things that prevent the crops from getting spoiled. Those herbicides would come in. They're herbicides called as self-phos. There's something called as cypermethrin. So these are things that you will get from those villages. Whereas when you come to the city side, you'll probably get antidepressant poisoning. You'll probably get, sometimes you may get an organophosphorus. Okay, you might get something like malathion poisoning, parathion poisoning. These are things you'll probably get in our country, in our city at least. But what you must understand is, when a patient comes to you, you know, classically abroad a patient comes to you with, he was okay, he was partying, and he's come back and he's all white powder on his face. That's how normally they come. You will see white powder on his face. The classical history comes, and he's like, he was having fun, and then at his house he basically overdosed his medicines, his cocaine, then he came to you. That's how usually they present. But in our country they present with a sudden unresponsiveness, and you will probably have a whole family coming in saying that this is what happened. So here it's very important as a doctor for you. Of course, we will come to the management, but as a doctor, you have to take the history very, very well. Very, very well. The history becomes very, very, very important. And in the history, the few things that you need to figure out is, when did this occur? Because why that when did this occur? Just like in stroke, we have last seen normal. Here we know we need to figure out when did this occur, because many of our treatments are directed with respect to time. Many of our treatments, which includes decontamination, which includes removals, the extracorporeal, as well as which comes with respect to antidotes, it's all related to time. So we need to know when this occurred. We need to try to figure out the quantity that they have taken. The quantity. It's very important that we figure out the quantity. To give you an example, if you have a village in nearby, and they've had a party at home, maybe a wedding at their place, they normally have a large amount of alcohol. Okay, so this alcohol, if it is even slightly not distilled properly, it will be methanol. It will be methanol. And if that not very distilled alcohol comes to you, you need to understand how much they've drunk, because there even 30 ml can cause problems. I understand. So the quantity is very, very important. When you have two poisoning or three, if you have three poisoning in one place, come from one place, it's called as an outbreak. So then outbreak management happens. Okay, you need to figure out source and things like that. Alright, so that's the history of the quantity. The third thing is, it's very important to figure out what is the poison that is taken. So circumstantial evidence, very, very important. So you'll have to ask them, did you find any tablets at home? Because it's not just one poison that they normally take. 50% of the times it's usually a co-ingestion. It's usually a co-ingestion. If he has to take one whole box, one whole bottle of tricyclic antidepressants, it will be co-ingested with an alcohol, or it will be co-ingested maybe with a kerosene. It will be co-ingested with something like that. So the history comes as, what did you find at home? Did you find tablet strips? Did you find bottles? Did you find anything further? Did you find anything, containers that are there at home? So circumstantial evidence, very, very, very important. Not only that, circumstantial evidence is also important, because what if he's just fallen off and hurt his head, he has a traumatic brain injury? Okay, so it may not be poisoning, it may be just traumatic brain injury that has brought him to the ICU. They would have found a strip, but it may be just TBI. So it's very important for you to actually figure out what is the circumstantial evidence behind this. It's not you had a fight in the family. It's circumstantial evidence to figure out what is the poison that is taken. So here comes the importance of asking their local pharmacies. Okay, so in the event that they say that we didn't find anything, and you strongly suspect that this patient is poisoned, then comes the example of local pharmacies. That means all the local pharmacies wherever the person was found need to be questioned to figure out whether somebody has taken a strip of these particular medicines. It's very, very important. So if you find the strip, that's a different situation. But if you don't, then it's very important that local pharmacies and local veterinary shops and local agricultural grain stores, these are the places that you'll have to search for. Many of these agricultural grain stores and pet stores also have these kind of insecticides, lice, mites prevention medicines, and these agricultural stores will have these rice pellets which are responsible for prevention of the rice getting spoiled. Okay, aluminium phosphide they contain. So we need to figure out whether it is coming circumstantially or from around that area. You'll have to take that history. It's very important. Okay, it's very, very important you have that history. I don't know if you remember, there was a case over here who basically had shifted from another hospital to this bed here, right? This bed. It was from another hospital in Kalyan, and it so happened that we didn't know nobody knew what kind of poisoning it was, and then we actually figured out it was ventilated. If you remember, on this bed here, ventilated here, yeah. And then we found from the local pharmacy, local veterinary store, that this guy had gone and bought some of these insecticides that are given to animals, and he had consumed those. So this is what we found, that he had consumed that from the veterinary store, which is available. The veterinary store, these are available. So that history taking becomes very, 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 very important for you. Very important. Okay. Then the moment the patient comes to you, obviously you need to, as I said rightly, you try to classify which kind of poison this is. You try to classify which kind of. You don't try to figure out the poison. You try to classify in which group the poison lies in. Okay, to figure out the poison, it's almost improbable because there are 400, 500 poisonings that can occur. We do not know which poison it is, whether it is this, that, but you can actually try to figure out the class of the poisoning. When I say class, it means what kind of poisoning it is. That's why you have the help of something called as toxidromes. Toxidromes is syndromic approach. Now all over our medicine, we are having syndromic approaches. All over medicine, we are having syndromic approaches. When you look at community acquired pneumonia, when you look at sepsis per se, we are looking at syndromic. When you look at blood culture and you're sending a panel, you are sending a syndromic panel, pneumonia panel, you are sending a meningitis panel, you are sending, these are the panels that you are sending. Syndromic approach actually helps you to come to narrow down your diagnosis. It comes to narrow down your diagnosis to something. So there are a few syndromic approaches that can happen in toxicology also. So the few syndromic approaches that you have would be 5 types of syndromes usually. And the first syndrome that you would think of in such cases would be, so let's divide it into different parts. The first syndromic approach is sympathomimetic toxidromes. Sympathomimetics. When you say sympathomimetics, what does the word say? Sympathetic system is working overboard, right? So most of these toxidromes are based on 4 characteristics. And those 4 characteristics is what you are going to look at. The first characteristic is vital signs. The first characteristic is vital signs, okay? The first characteristic will be vital signs. Right? The second characteristic will be secretions. Okay? The third criteria will be eyes. And the fourth will be skin. So these will be, all your toxidromes would be actually divided into these parts. It will be divided into vital signs, what are the secretions, what are the eyes, and what are the skin. This is all that you need to see when you see toxidromes. It's not, when you think of toxidrome, you feel very scared, कि अरे इतने सारे चीजें हैं, कैसे मुझे पता चलेगा, right? That is what you think. But you have to remember this, toxidromes are only these 4 things. Their vital signs, their secretions, their eyes and skins, and by the end of now, we'll understand how simple it becomes. Okay, so here, the first constellation of toxidrome that I would talk of would be actually sympathomimetics. sympathomimetics. Now I don't need to even tell you what you'll see here. What will you see here? Tell me. What are vital signs you'll see? If there's sympathetics, when you're giving adrenaline, what will happen? Yeah. So you have in vital signs you'll have tachycardia, you will have hypertension. Now let's come down to secretions. What about secretions? Nothing happens to secretions. Remains the way it is. Nothing happens. It's normal. Nothing happens. When you give adrenaline, secretions don't increase. Right? If nothing happens to secretions per se. Eyes? No, dilatation. No. When you give adrenaline, whenever you have a patient of cardiac arrest, when you give an adrenaline on a big dose, what do you see? You see dilatation, right? You see dilatation. So your mydriasis. So you will have mydriasis when it comes to eyes. Skin, it can be normal, nothing specific. It can be nothing on that. So the toxicodrome is so simple when it comes to sympathomimetics. What happens is just remember adrenaline. Okay, sympathomimetics में क्या होने वाला है? You're going to have a hypertensive response and a pulse rate that is going to be fast. Okay, you're going to have secretions that are normal or maybe equal or reduced, slightly reduced. Eyes is going to be mydriatic. There is going to be dilatation because that's what's going to happen in sympathomimetics. It's get dilated. It's going to become bigger, right? And skin, it can remain normal to whatever it is. And when we are talking about skin now, always the skin that we're talking about is usually the axilla. Okay. So usually, if you want to see changes in the skin, no, the axilla is the place where you have to touch. Okay, sympathomimetics. Clear on the sympathomimetics? The other system that you can talk about very simply is the anticholinergics. Okay, so anticholinergics, what do you think it is? Organophosphorus, right?
Yeah.
So what happens in that? What happens to the vital signs there? There's bradycardia. Okay, there's bradycardia, right? There's brady happening, right? Bradycardia. They may or may not have hypotension. They may or may not have hypertension. It depends on which kind of organophosphorus poison. When you come to OP, we'll discuss that. But may or may not have hypotension. But yeah, okay. May or may not have. But bradycardia is very prominent. Then what happens to secretions? Increases. Secretions increases. So the secretion will increase from all orifices. Let it be diarrhea, let it be urination, let it be salivation, let it be lacrimation. Everything will increase. Just simple lacrimation you might have. Just lacrimation. Okay. So this is what you probably have in these cases. You'll have vomiting. Okay. So basically you're losing a lot of fluid from here and there. One of the reasons for hypotension in that case is usually loss of a lot of secretions from here everywhere. Clear? Lacrimation. Eyes? Miosis. So you'll have miosis. You have pinpoint pupils. And skin? Yeah, so it's more sweaty. Okay, it's more sweaty. It's not dry. It's sweaty. It's sweaty. That's why it touch the axilla in these cases. It will be sweaty. It will be sweaty. So it's very simple to remember this. This is very simple to remember. Then the other part of the story is cholinergic, right? So in cholinergic, what do you have? Just the opposite of all of these, right? So when you think of cholinergic, when we were in MBBS, we always thought about datura poisoning. And what did we talk? That mnemonic?
Sludge.
No, that was sludge is for organophosphorus. Don't make this mistake, please. So we say dry as a bag, mad as a hatter, red as a hair, hot as a hair. Remember this? So we talked about that thing. So that is exactly this. Okay. So what happens to the vital signs? Tachycardia. Okay. You'll have tachy here. Then secretions? Dry. Eyes? Blind as a bat. Blind as a bat. Myotic. Okay. Myotic. And skin? Dry. Dry as bone. Barabar, na? We used to call it as mad as a hatter, agitated. Now we used to call it dry as a bone. We used to say blind as a bat. ऐसे सब बोलते थे ना उसके लिए. That is exactly what that cholinergic poisoning is. So now you know 3 toxidromes already. You know 3 toxidromes. You know sympathomimetic toxidrome. You know the cholinergic toxidrome, and you have the anticholinergic toxidrome. The next toxidrome is sedative hypnotic toxidrome. Sedative hypnotic. Okay, a sedative hypnotic toxidrome. What will happen to the vital signs? Bradycardia, or normal. It can be bradycardia or normal. Respiration is going to be low. So the respiration is going to be low in the vitals. You have respiration that is going to be on the lower side. Secretions dry. Nothing on this. Eyes dilated. Okay, dilated. Okay, you have eyes to be mydriatic. And skin dry. It can be dry or normal. Okay? Clear on this? Yes. This is sedative hypnotic. The characteristic feature you have is the patient having a bradycardia and a low RR. This is the only place where the RR is coming down in the vitals. The RR is coming down, right? So you have low pulse rate and the RR coming on the lower side, right? So this is a sedative hypnotic. But there is nothing else. Secretions and skin has no problems, right? Then the last oxydrome you have, which is actually on its own, is opioid. Now the opioid, it remains as similar to the sedative hypnotic, but the one difference is, the one difference that you have is myotic pupils. Okay, the only thing you have is myotic pupils here. Okay, so meiosis is there. It is the same as sedative hypnotic, but it is myotic. So by knowing these toxidromes, I'll just repeat them. The 5 toxidromes we talked about. We talked about sympathomimetic, we talked about anticholinergic, we talked about cholinergic, we talked about sedative hypnotic, and we talked about opioid. So by just knowing this, you are almost ready to treat. Remember this, you are almost ready to treat by just knowing so much. You are almost ready to treat. But most of the things you will probably be able to treat by just knowing so much. But this is how you also give the history. When you are giving a history to somebody, after you give the circumstantial evidence, then you are supposed to give this history to the senior person. You know, what is the history? This is what it is. This is what I am seeing in the vitals, this is what I am seeing in the secretions, this is what I am seeing in the skin, and this is what I am seeing in the eyes. These are the things you need to tell. Okay, because then the toxidrome comes in place. It looks like a sympathomimetic toxidrome, or it looks like a cholinergic toxidrome. That is how it comes. That is how we start thinking. And that toxidrome I need to tackle. Clear? Clear on the toxidrome yet? Yes. Clear now? No problem till now, toxidrome. So it's very simple. It's not difficult. Let's not make it very complex. You can make it really complex, but you don't want to make it complex. This is how it should be. Right? Clear? Yes. Alright. So this is when a patient comes to you. Right? Now what are the investigations and why do you do them? That you should know. If you are doing an investigation, why are you doing the investigation? So if the patient has come into you, the usual investigations are because you have to rule out mimics, hypoglycemia, so finger stick glucose. Patient is not going to have a toxic problem immediately after a certain ingestion. The hypoglycemia may be the cause of everything, it may not be anything. So hypoglycemia. Calcium, magnesium, phosphorus needs to be done. Calcium, magnesium, phosphorus needs to be done. A CBC electrolytes is a routine investigation that we are doing in such cases because you don't want to mix 2-3 things together. But there are certain specifics. Now, some specifics that you should understand in the first place is the ECG. Okay, in a toxicology screen, and you're thinking of toxicology, you should do the ECG. And why is this ECG done? The ECG is done usually to figure out one, you don't just see 2 leads in that. Which are the 2 leads you see? AVR. Okay, why you want to see the AVR? Pulse rate you can see on the screen, you're not really worried. But I want to see the AVR because what happens is in sodium channel blockade, in poisonings which have sodium channel blockade, in that you have the R wave to be very prominent. Okay, you have in the AVR, you'll have the R wave to be very prominent in sodium channel blockade. If a person has taken a large amount of didocaine, a large amount of, this was available, they've taken a large amount of these prokinamides and things like that, you'll have a very large R wave in the AVR. Right, and the other ECG finding you want to find out is the QT. Okay, the QT, which is basically synaphodon for potassium channel blockade. Potassium channel blockade. So if there's potassium channel blockade, the QT is going to be prolonged. Okay, so when the QT is prolonged, the QRS is also prolonged, and that is one of your treatment guides for TCA poisoning. You understand? So TCA poisoning, that's what is one of your this for tricyclic antidepressants. One of the things that you're going to correct is the QT, the QRS, right? So prevention of torsade comes there. So it's one of those places where you have potassium blockade, we want to give potassium. You understand? Clear on this? Clear? ECG is clear? Then comes the important thing about sending a urine toxicology screen. However, the urine toxicology screen is neither sensitive nor specific. It's an absolute useless test in the first place. Okay, why is it a useless test? Because very often it has got false positives. Very often. Even your brufen will come out as barbituric. Your brufen will be picked up as barbituric. Are you understanding? Even some similar drugs will be picked up as actually intoxicants. Which is not the scene. It's not very specific. The only specific thing you can pick up in a urine toxicology screen is cocaine. Okay, the only thing you can pick up is cocaine. You can't pick up anything else in a urine toxicology screen. Clear? But then why do you do it? You do it because, okay, you may be having this group of poisoning. If this is this group of poisoning, now I need to send what? I need to send something called as mass spectroscopy. Okay, if I want to figure out what is the toxin, I need to do something called as mass spectroscopy. Okay, that's the poisoning. That's how I'll find out. So urine toxicology screen cannot be held in a court of law because of this reason. You understand? Though you will do it, but you will not really. Another problem with urine toxicology screen is this patient has come in, somebody has given him a midazolam. Or if this patient is on antidepressants, what is the point? It doesn't give you quantity. You understand? It doesn't give you quantity. For example, he is on antidepressants. Now, if he is on antidepressants, how can you say that this is TCA poisoning? You cannot say that because it is not giving you quantity. It's just telling you, okay, I found something in that. Are you understanding? So, urine toxicology screen, apart from giving false positives, when it really does not, it has got a finite set. It will not detect the whole 400 toxins that you have. It's got a finite set. You understand? It will not tell you everything. So, it doesn't tell you immediately everything also. You understand? So, it's not very sensitive. It's not very specific, and at the same time doesn't give you qualitative reasons or quantity. You understand? For example, you have a patient who's come and was in a periphery. He went over there, they found his GCS to be low, they have given midazolam, intubated. Now you come back and do a urine toxicology screen because you have it. You will get midazolam there. Midazolam is not the cause of his poisoning. It will be taking you to a wild goose chase. Are you understanding? So a urine toxicology screen, you may send it, but you must understand the limits or limitations of urine toxicology screen. Okay, there are two kinds of screen when you send over here. One is a 7 drug, one is a 21 drug. You have to decide which you want to send. You can send 21, you can send 7. That's why to understand this, it's important to have the toxidrome in place. You understand? But the test of choice in such cases is urine toxicology. If you are in the periphery, urine mass spectroscopy, right? If you are in the periphery, there is one particular poisoning called as phosphine poisoning. Cell-phos karke, very important poison is there. It's very easily available. One of the regulated poisonings that are available to for pesticides, as pesticides. It actually creates phosphine gas. Okay, it creates phosphine gas, and it's a very common cause of poisoning in Vidarbha region, where there is a lot of farmer suicides. One farmer suicides every 30 minutes is what they say. This is what they say in our country. Okay, one farmer suicides every 30 minutes. Okay, that's the kind of suicide rate that we have in our country. And what we get is cell-phos poisoning usually very often because it's easily available. It's easily available when you are in that agricultural community. It is available. So this cell-phos poisoning also can be detected by a test in the urine. A test in the urine, which is a silver nitrate test. I don't know the full form, dithionite or something it's called, the test, but it is a silver nitrate test. The silver nitrate is very different there. Okay, you use that strip, put silver nitrate, and the strip becomes black. Right? So you get cell-phos poisoning. Right? So urine can be used for that purposes. Can urine be used for alcohol? Again, it can be used to actually figure out permissible limits, but it is serum levels that we want to check for alcohol. Serum alcohol levels are not available. Why are these alcohol levels done? A, for a forensic test, that to prove the fact that he has been drinking and what are the limits. Second, there are certain alcohols that will require a certain level for purposes. For example, if your methanol level is more than 30 milligram per dl, methanol, I will need to go for dialysis. You understand? I need to do my alcohol levels also to figure out whether I am therapeutic also. That will come to that later when we do methanol poisoning. Right? So you will need to do the test for that. Right? These are the investigations that you will want to use in these cases. And of course, if there is a focal neurological deficit, you will first rule out whether there has been an epidural hematoma or a subdural hematoma or an infarct before all of these things, which is mimicking your toxicology. Right? So a focal neurological deficit should always ring a bell in your mind, thinking this is not toxicology, this is something more. Okay, a focal neurological deficit you should be always careful of. Okay, that's why physical examination is very, very important in such cases. Right? Physical examination becomes very, very important in such cases. Now the general approach to these poisoning is, after I've seen the last scene normal or approximate time of when he's had whatever he's had, the next question that you ask in the history is, has he had vomiting? It's very, very essential to ask this question. And why is that so? Why do you think that is so? Why do you think that is so?
Most of the poisoning.
Almost 40% of the poisoning is out. Almost 40% of the poisoning is out. Once your poisoning has happened, almost 40% of the poisoning is out. Okay, so you are not dealing with a larger quantity probably. It will probably be beneficial for this particular patient. This history is very, very important. Also, when you have the patient coming in within an hour, you can actually induce vomiting. You can actually induce vomiting. In fact,
the treatment of choice for such cases which have come in suddenly, immediately, or at home is actually inducing vomiting, for which you can use whatever you want, salt water, Ibuprofen syrup. These are a lot of things that can be used for inducing vomiting. Okay, for inducing, not given a force. That is for lavage. Okay, this is for inducing vomiting. Clear? You can induce vomiting and that will probably help. But few cases in which you will never induce vomiting is when the patient is neurologically down. Never and never do that. If the patient is slightly also drowsy, I will not induce vomiting. If this patient has corrosive poisoning, I will not induce vomiting. It's not something I will do. Okay, I will not induce MSS in these cases. Very often the patient will be at a time when you cannot induce MSS any which ways, and you will end up doing a gastric lavage. Now, what is a gastric lavage? So, as a doctor in the ICU, you should understand before you even go to gastric lavage, the most important thing is decontamination. Okay, decontamination. When I say decontamination, it means remove the clothes completely, remove the clothes, dispose those clothes, completely remove the clothes, and then irrigate the patient with soap and water. Completely clean the patient with soap and water. When that is happening, the person who's doing this also should be wearing personal protective equipment. Okay, mucosal areas need to be cleaned, even in fact more violently, by a higher amount of irrigation liquid. For example, eyes. Have you all seen any ER where they use all this equipment? Where they use these. So if you go to if you go to the outskirts, no, if you go say to Apollo Hospital, which is at the outskirts, it's not in this. So they will have more amount of poisoning coming from the agricultural areas around that area. Or you go to Palghar. So these places all now they will have a device which is like two specs. उसमें से पानी आता है. ऐसा stand रहता है वो, and that stand they put in their eyes like this. So it irrigates the eyes. So liters of water is irrigated. Mucosal areas have to be irrigated as much as possible. So when you are here and you think that there is poisoning, you irrigate. When I say irrigate the mucosa means take 50 cc or 20 cc of water, open the eyes and irrigate the eyes. Irrigate the eyes. Are you understanding? The whole place should be full of water when such patients come in. So in the rural areas which have got some good hospitals, okay, there they have even showers. The patient is taken inside, patient is undressed, and the shower is put on and completely showered off. Shower inside the ER. Okay, they completely showered, so it comes off. Completely comes off. Okay, so when I was working there also there was everything, because we were always worried about Israel was always worried about chemical warfare. So since they were worried about chemical and bio warfare, there was always these things ready over there. So this you can see in Apollo. If you go to Apollo Navi Mumbai, you'll see this. If you go to Marriott in Chennai, you'll see this. It's there. Okay, all these things are there because these are those areas which will deal with all these things. Right? So decontamination becomes a very important process. The next thing is try to remove the toxin. Decontamination first, so skin decontamination ho gaya. Second thing is GI decontamination. Now, as he rightly said, GI decontamination would occur by a few methods, of which first is removal. And as a removal, it means what? Two things: gastric lavage and whole bowel irrigation. Okay. Now, how do you do a gastric lavage? What do you feel?
Sir, we have to put one red rubber or a RT and followed by.
So first you have to put a very large bore RT.
Yeah.
You cannot put a small bore RT, because if you also trying to remove the capsule or tablet if there is inside.
Yeah.
Are you understanding? So the abroad there is a tube called EWALD tube, EWALD. EWALD tube is a drug that is a tube that is used, but otherwise you will use the largest RT available in the hospital to put the rice tube. Before you do gastric lavage, it's important that the patient is fully conscious. If the patient is not fully conscious, then you first intubate the patient. Right? And then do a gastric lavage. Right? You never do a gastric lavage in a person who is drowsy. It's completely wrong to do that. Because when you're doing the insertion process, there can be an aspiration, and once that aspiration occurs, the patient will go into ARDS and things like that. So no, it's not supposed to be done. If the patient is not conscious or is semi-conscious or is very drowsy, don't do the gastric lavage. Don't do the gastric lavage. If you think you're not going to intubate, don't do the gastric lavage. Very important what I'm telling you. समझ में आ रहा है? Don't do gastric lavage. It will add insult to injury. Alright. So to do a gastric lavage, you will put a very large bore nasogastric tube. Okay, very large bore nasogastric tube. You will verify whether the tube is in the right place. It's very important to verify whether the tube is in the right place. And then you will put, what will you put?
Then we have to remove little eval tube.
No. So what you're supposed to do is you have to, it has to be done with gravity. It cannot be done with suctioning. It has to be done with gravity. You will put 200 ml of warm tap water. What will you put? 200 ml of warm tap water. You don't want to put normal saline. Normal saline has chlorine. It has chloride, it's got sodium. We don't want those electrolytes inside the body. We want normal tap water. We're cleaning the stomach. So patient will be in left lateral position to prevent this from going down. Patient will be in left lateral. When the patient is in left lateral, the transit of the water will be much lower to the lower part of the intestine. Patient will be in left lateral. Okay, you will insert 200 ml of warm tap water inside, and then by put this patient on the lower side, you will just put the right tube down, the water will come outside. You understand? Like how we do in, when you keep continuous RT, what happens in continuous RT? Water is coming out regularly because नीचे से ऊपर से आता है वो, right? So you just keep the RT down so that the water starts coming down. You will keep doing this. You will keep doing this till the RT becomes clear. Till the water that is coming back becomes completely clear. This is called as gastric lavage. This is called as gastric lavage. Okay. At times you may want to use KMNO4, but there are specific poisons in which you use KMNO4. But otherwise, tap water is more than enough. Tap water. Warm tap water is supposed to be used when using gastric lavage. Okay. Now, if you have this poisoning, and this is done only when the patient is within 1 hour. Within 1 hour of ingestion. Within 1 hour of ingestion. However, if the patient is, you have done a gastric lavage, usually with the gastric lavage, the next step is to actually instill activated charcoal. Have you seen activated charcoal?
Yeah.
Where have you seen it?
Flat
The package sign there is a bottle.
So if you put activated charcoal on Amazon, you will get proper bottle. Grams में आता है वो, मतलब scoop में आएगा. Lekin we don't use that. Okay, we use tablets. There are tablets called as Dystinil. Flatulina, Dystinil. They are activated charcoal. They are activated charcoal. Very difficult to use activated charcoal.
Yeah.
Very difficult to use activated charcoal because it smells, it tastes like mud. So you can't tell a person drink activated charcoal. If you put it to the right tube, it gets blocked.
Yeah.
You understand, get stuck. So it's very difficult and messy job to do. So ideally, if the patient is fully conscious and obeying commands, you would take activated charcoal, powder it to very fine amounts. Powder it to very fine. It takes a long time to powder that charcoal. You powder it to very fine amounts. Put it in a very strong juice like cranberry juice. Cranberry juice is a very strong juice. Cranberry juice. Put it in cranberry juice, mix it, make a slurry out of it, and tell her to drink it. Him or her to drink it, right? If he is not drinking, then you of course have to, as much as possible, powder it to minimum amounts, put water in it and let it go through the Ryle's tube, right? Activated charcoal. What is the meaning of activated charcoal? What is activated charcoal?
It absorbs the.
What is activated charcoal? Why not just charcoal?
I mean, the form.
So when you heat a coconut shell, when you heat wood, when you do all these things and you burn them, you form charcoal. You form coal, right? You form charcoal. It charred it, you charred it out. It becomes charcoal. When you heat treat it and you pressurize it, it increases the surface area. That is the meaning of activated charcoal. 1000 to 3000 per meter square उसका surface area बढ़ जाता है. When they activate it, they are treating it. They are treating it with some technology which actually causes the surface area to increase, Clear? That's why it's called as activated charcoal. You understand? That's why it's called activated charcoal. You can't use. That's why, if you don't have activated charcoal, what is the best thing? Who drinks here? कौन पीता है इधर? कोई नहीं पीता? Burnt toast is charcoal. So if you have had so much of alcohol and you just feel it's too much, burnt toast is the best thing because it will absorb the rest of the charcoal. You understand? It is like the rest of the alcohol that's lying in your abdomen and not gone ahead. So burnt toast. So in this case, you're using that same toast, like same thing, activating that to increase the surface area so that it absorbs, right? So the usual dose of activated charcoal is usually 1:10. That means if you have 1 of activated charcoal, 10 of the drug. 1:10 is the dose. Okay, that is the dose. But however, we don't know the amount anytime. We never know the amount. 1:10 is the dose of activated charcoal. Okay, however, we will never know the dose, and that is why we take the dose to be equal to the body weight. 1 to 2 milligram per kilogram, 1 to 2 gram per kilogram. That is what we take. It will not be, when you are ordering Destinil, that is in milligrams. So you need to buy maybe 10 strips, 20 strips, 30 strips of that particular Destinil that we have, Platinum that we have. You understand? To make it 50 grams. Somewhere to make it 50 grams, you need to have maybe 50 strips of Destinil. You understand? To make it, it's a cumbersome job actually to get that. Clear? Activated charcoal? Clear? So there is something called as multi-dose activated charcoal. So what happens is you have given charcoal, okay, and then a couple of hours later you give it again. That's called multi-dose activated charcoal, which you can give for drugs that reduce the gastric transit time. So there are opioids you take. Opioids are reduce the gastric transit time, so the medicine will still be there in the unit in that particular place. So you give another dose 2 hours later. That's called multi-dose. So it's given three such doses are done. This is called multi-dose activated charcoal. So activated charcoal, multi-dose activated charcoal. But you must know that activated charcoal will not work on many of the common poisonings. For example, it will not work for alcohol poisoning. It will not work for organophosphorus poisoning. It will not work for hydrocarbon poisoning. It will not work for lithium. It's not going to work for these poisonings. It's not going to work for opioids. It's not going to work for many of these poisonings that we know about. Right? So there are only few poisonings in which activated charcoal will work. Clear? So you must remember this, it doesn't work for organophosphorus because that's what's common. It never works for alcohol, that's what's common. It doesn't work for these two. Right? Unknown poisoning, less than 2 hours, give it. Right? Unknown less than 2 hours, give it.
What if it's like multiple drugs like
Give it.
benzodiazepine?
Unknown poisoning, give it.
Give it.
Unknown poisoning, give it. Provided you are within that 1 to 2 hour window and the patient is fully conscious. Because activated charcoal, if it goes into the lungs, it will cause ARDS. If activated charcoal goes into the lung, it's like swallowing mud, no?
Yeah.
It's like swallowing mud. It will cause a reaction inside the lungs. It will become, you will go to fibrosis and things like that. So it's very dangerous to do that otherwise. If the patient is fully conscious, the easiest method is that. You understand? The patient fully conscious, the easiest method is that. Even in by biblical times, even mythological times, if you hear Mahabharata, Ramayana, he has had a poison. He has had mud after that. ऐसा आता है उसमें.
Yeah.
He has had mud after that and he survived. That's what even they say. So it's something that has always been there. So activated charcoal. Clear? This is a form of GI decontamination. The other form is gastric lava we talked about. And the third part is whole bowel irrigation. Now what is whole bowel irrigation? Whole bowel irrigation is you are trying to, what you are doing for a colonoscopy, that is whole bowel irrigation. Liters of fluid you are giving through the oral tract. Liters of fluid you are giving so that it flushes out from inside. So what will flush out? It is supposed to be done for body packers. So body packers, there are people who come smuggling from somewhere, they pack drugs into plastic packets and condoms and then they swallow that. Okay, they swallowed it, is there in the system. We want to take it out of the system. To take it out of the system, you give them whole bowel irrigation using peg leg. You understand? So this is whole bowel irrigation. Okay. Clear? Multi-dose activated charcoal was also called as GI dialysis. Okay, it was also called as GI dialysis because it actually forced alkaline diuresis was also called as GI dialysis. There's something called forced alkaline diuresis. For example, in salicylate poisoning, that is another form of removal of toxin. Where how do you do forced alkaline diuresis? You actually take a liter of 5% dextrose. Okay, you put in that 50 cc, 100 cc of sodium bicarbonate and keep it at 250 ml per hour. So over 4 hours your 100 ml is going of sodium bicarbonate. You look at the pH. If the urinary pH is more than 7.4, you have done your job. That's called forced alkaline diuresis. Forced alkaline diuresis. It comes with its own problems which includes fluid overload and metabolic alkalosis. Right? Forced alkaline diuresis. That's another form of removal of toxins. And then when you come to the next removal of toxins, you have hemofiltration, hemoperfusion and hemofiltration and hemoperfusion. This is the two things, and dialysis, hemodialysis. So there are three forms of removal of toxin. Till now it was removal from the GI tract. You have hemodialysis, you have hemofiltration, and you have hemoperfusion. There are three different things. When you say hemodialysis, means you are using a dialysis filter. So all those poisonings that have very small molecular weights, they can be dialyzed, like alcohol. Very small molecular weights, very low protein binding can be taken out from hemodialysis, and very low volume of distribution. If a volume of distribution is too much, dialysis will not take it off. Okay, when I say very low volume of distribution means less than a liter. Less than a liter per kilogram. Okay, that is hemodialysis. So that's a form of removal. Then you have hemoperfusion. Hemoperfusion is when the volume of distribution is higher, and at the same time the molecular weights are higher. Okay, the molecular weights are higher. So if here the molecular weights are less than 1000, less than 5000, here it is more than 50,000. Anything between that is hemofiltration. Anything between that is hemofiltration. Somewhere anything between that becomes as hemofiltration. Clear? Clear? Every completely different technologies. Hemodialysis is when you use a dialysis filter. Hemofiltration is when you're doing a CVVH. CVVH, continuous venous hemofiltration, we do CRRT. That is hemofiltration, we're using convection. Here you're using diffusion, here you're using convection. Whereas here you're using adsorption. Adsorption means there's a filter, this is charcoal filter, and your drug is getting attached to the charcoal filter. Hemoperfusion, or some kind of filter, polycarbonate filter is there, which is getting attached. So there are various filters. This is adsorption. Okay, this is adsorption, this is convection, and this is diffusion. Clear? And after all this comes antidote. Okay, antidote. So you should have the antidote specific for that particular poisoning, and we'll come to that when we come to specific poisoning. So this is general approach to poisoning. Any questions on this? Any question on general approach? You can stop it.